Hello, all. Good morning. I am Dr. Hia Boro. I'm an endocrinologist practicing at Sharjah, UAE. I completed my endocrinology training from the prestigious AIMS, New Delhi, India. I always have had a passion for teaching endocrinology and disseminating the knowledge of endocrinology among everyone. So, welcome to my YouTube channel, Endocrinology Notes. These classes or these lectures are particularly valuable. These are designed to be valuable resource for the residents worldwide who are seeking to deepen their understanding of endocrinology and the aspirants who are trying to crack various endocrinology entrance exams like NEET and super specialty exams in endocrinology and entrance exams particularly, and also the healthcare professionals who are looking to enhance their knowledge and skills of endocrinology. And these notes are primarily based on the standard textbook, that is the Williams textbook of endocrinology. So without wasting time, let's begin our first lecture. This lecture is based on chapter number 19 of Williams. This covers the endocrine changes in pregnancy, part 1. So let's discuss the maternal endocrine changes. So as we know that pregnancy is a condition where there is tremendous hormonal changes. Pregnancy triggers significant changes in the entire hormonal milieu, and it significantly impacts the pituitary gland, the thyroid, the parathyroid, pancreas, and the adrenals. So now let us begin the session with a question. Which of the following enteropituitary cells are maximally increased in pregnancy? A. Lactotrophs, B. Somatotrophs, C. Gonadotrophs, or D. Corticotrophs? Yes, the answer is A, that is lactotrophs. Now let us see what changes are undergone by the pituitary gland during pregnancy. The enteropituitary gland in pregnancy is enlarged by an average of 36%, which is quite significant, 36%. There is a tenfold increase in lactotroph size and number. Somatotroph and gonadotroph numbers are reduced. This is expected because the functions of somatotrophs and gonadotrophs are reduced in pregnancy, and therefore their numbers are also reduced, and there are no changes in corticotroph or thyrotroph numbers. The estrogen levels, which are increased in pregnancy, they are primarily responsible for increase in lactotroph size and number. So it is the estrogen which is actually causing a drive in the increase of size and number of the lactotrophs. Now, what happens to the prolactin hormone in pregnancy? The prolactin hormone rises tremendously, reaching a level of up to 207 nanogram per ml, in contrast to a mean of 10 nanogram per ml in non pregnant premenopausal women. Prolactin is also present in the amniotic fluid, and the amniotic fluid prolactin appears to be primarily of placental origin. Serum prolactin rises throughout the pregnancy, and the levels return to non pregnant states around 7 days postpartum. Unless the mother breastfeeds, breastfeeding helps in maintaining elevated prolactin levels. Now, what happens to the prolactinomas, which are the tumors of lactotrophs, during pregnancy? Now, as we know, prolactinomas can be of two types: microadenomas, which are less than 10 millimeter, and macroadenomas, which are more than 10 millimeter. Now, in a study which was quoted in Williams' textbook, this study involved 352 women with untreated microadenomas. Among these, 2.3% reported visual disturbances, 4.8% experienced headache, and 0.6% developed diabetes insipidus during pregnancy. On the other hand, if we look at the numbers with macroadenomas, the complication rates were significantly higher. 15.3% experienced visual disturbances. Similar percentage also reported headache, and 2.14% developed diabetes insipidus. So this is quite high compared to the percentages we observed in microadenomas. Now, how do we manage prolactinomas in pregnancy? So as we know, outside pregnancy, the drug of choice for managing prolactinoma is the selective dopamine 2 receptor agonist, that is cavagoline. However, cavagoline is, it is not commonly used in pregnancy. So once the woman gets pregnant, we do not prefer using cavagoline. Rather, we prefer using the short-acting dopamine agonist, that is bromocriptine. So bromocriptine is the drug of choice for management of prolactinomas in pregnancy. In some cases, surgery, that is transsphenoidal pituitary resection, may be required, particularly if there is rapid tumor growth or the patient is experiencing mass effects like severe headache or deterioration of vision, despite the treatment with bromocriptine. So that was about the prolactin hormone in pregnancy. Now let's see what happens to the growth hormone in pregnancy. Now, question number 2. This is about growth hormone. Which of the following statements is incorrect? Placental growth hormone is secreted in a pulsatile manner. Placental growth hormone is secreted by the syncytotrophoblast. Pituitary growth hormone in pregnancy decreases in the second trimester. Maternal serum IGF-1 increases in the second trimester of pregnancy. So, which of the following statements is incorrect? Yes, the answer is A, that is placental growth hormone is secreted in a pulsatile manner. We know that growth hormone is usually secreted in a pulsatile manner. The primary source of growth hormone is the pituitary gland, the somatotrophs. However, in pregnancy, there are two sources of growth hormone, the pituitary as well as the placenta. The pituitary growth hormone is known as growth hormone 1. The pituitary growth hormone decreases after 25 weeks of pregnancy. The placental growth hormone variant, which is known as the human growth hormone V or growth hormone 2, it takes over in the second trimester and it is responsible for maintaining the IGF-1 levels for fetal growth. Placental growth hormone, unlike the pituitary growth hormone, is secreted in a non-pulsatile manner by the placental syncytotrophoblast. Now, what happens to the IGF-1 levels in pregnancy? Maternal serum concentrations of IGF-1 are elevated during the second half of pregnancy. It is due to the combined effects of the placental growth hormone variant as well as human placental lactogen. We will discuss regarding human placental lactogen in the next class. We'll be discussing in details. But just remember that human placental lactogen also has a somatotropic biological activity and its serum concentration increases throughout pregnancy, paralleling that of IGF-1. Okay, now the next hormones in pregnancy are the thyroid hormones in pregnancy. So thyroid hormone also undergoes significant changes. Now coming to this question, question number 3, which of the following statements is incorrect? A, TSH levels fall in the first trimester and then plateau in the second and third trimester. Low TSH levels in the first trimester can be attributed to rising HCG levels. Response of TSH to exogenous TRH, that is thyroid releasing hormone in pregnancy, is blunted. Nadir TSH is observed at 10 to 12 weeks. So, which of the following statements is incorrect? Think about it. Yes, the answer is C. This statement is incorrect. The response of TSH to exogenous TRH in pregnancy is blunted. This is an incorrect statement. The response is not blunted. So we can see that the mean TSH level significantly lowers in the first trimester. So as the woman becomes pregnant, there is a drop in the TSH level. This drop is particularly observed in the first trimester compared to the second and the third trimester. Now, why does this drop occur? This drop occurs because of the intrinsic thyrotropic activity of the human chorionic gonadotropin. So during the pregnancy, there is a rise in the human chorionic gonadotropin levels. So this human chorionic gonadotropin, it has got an intrinsic thyrotropic activity, which in turn causes suppression of the pituitary gland, leading to a suppressed TSH level. This nadir TSH corresponds to peak HCG level, which is observed at 10 to 12 weeks after the last menstrual period. There is a reciprocal relationship between the rising HCG level and falling TSH concentrations. So this is also clinically significant because most of the time we as endocrinologists, we get to see referrals from gynecologists for low TSH in pregnancy. So every low TSH in pregnancy is not an indication for starting antithyroid drugs. Low TSH in pregnancy, particularly in the first trimester, is very, very common. And in such patients, you should reassure the patient that TSH levels will return to normal in the second and the third trimester. And this is physiological because of the rising levels of HCG, which have got intrinsic thyrotropic activity. So this is clinically significant. Higher HCG levels are associated with higher T4 levels. Despite the lower TSH levels during early pregnancy, the response of TSH to the exogenous thyrotropin releasing hormone is normal. So this was what was asked in the question, whether the response of TSH to TRH is maintained or not. So the answer is yes. The response of TSH to exogenous TRH is still normal in pregnancy. So this graph actually shows the concentrations of serum TSH and human coronary gonadotropin. Between 8 and 14 weeks, there is a significant negative correlation between the individual TSH and HCG level. So as we can see, as the HCG level is increasing, there is a drop in the TSH levels. And there is a negative correlation between the individual TSH and the HCG level. And there is also a linear regression of the maternal serum thyroxine and the HCG concentrations. So HCG and this T4 levels, they are positively connected. And as there is a rise in HCG level, there is also a rise in the free thyroid hormone levels. So that was about the thyroid hormones in pregnancy. So remember that even if the TSH is suppressed in the first trimester of pregnancy, it is not an indication for starting anti-thyroid drugs. However, the important thing is that if the patient is exhibiting serious symptoms of thyrotoxicosis in the first trimester, then you have to differentiate between Graves' disease and a gestational thyrotoxicosis. For this, there are certain tests which we will discuss later. The important test to differentiate is the TSH receptor antibodies. If the TSH receptor antibodies are elevated, that is more indicative towards Graves' disease. If the antibody levels are negative, then it is physiological, or it can be gestational thyrotoxicosis because of high HCG levels. Now, what happens to ACTH levels in pregnancy? Question number 4. Which of the following is true? ACTH levels remain constant throughout the pregnancy. The placenta does not produce ACTH. There is no relation between CRH, that is cortisol release hormone, and ACTH in pregnancy. ACTH levels return to pre pregnancy state after 7 days of delivery. So, which of the following statement is true? The answer is C. That is, there is no relation between CRH and ACTH in pregnancy. This is the true statement. The maternal adrenocorticotropic hormone, these levels rise during pregnancy. They do not remain constant, they rise during pregnancy. There is a fourfold rise which is observed between 7 and 10 weeks of gestation. Fivefold rise can be observed between week 33 and 37. There is a 50% drop of ACTH just before labor. However, there is a marked 15-fold increase during the stress of delivery. So, as we know, this ACTH and cortisol, they are stress hormones. Just before delivery, there is a 15-fold increase in the ACTH levels. The ACTH concentration returns to the pre-pregnancy level within 24 hours of delivery. So, it's not 7 days post-delivery. It is within 24 hours, the ACTH level returns to normal. The pituitary gland and placenta are again sources of circulating ACTH during pregnancy. Exogenous corticotropin release hormone, that is CRH, it stimulates the release of ACTH from both the pituitary and the placenta in a dose dependent manner. There is no relation between CRH and ACTH during pregnancy. It's a very important statement. It was the correct statement which was asked in the question. There is no relation between CRH and ACTH during pregnancy, unlike in the non pregnant state. The circadian rhythm and the ability to respond to stress are, however, maintained throughout the pregnancy. There is also a blunted ACTH response to exogenous CRH. However, the response of ACTH to vasopressin is maintained during pregnancy. So there is a blunted response to CRH, but the responsiveness of ACTH to vasopressin is maintained. Elevated maternal CRH likely downregulates the CRH responsiveness. Now coming to the next hormones, it is the arginine, vasopressin, and oxytocin levels in pregnancy. So arginine vasopressin levels, as we know, they are responsible for maintaining the osmotic thresholds in the body. The AVP levels are similar to that in the non-pregnant state. Increased AVP synthesis is balanced by higher metabolic clearance via the enzyme vasopressinase. So although AVP is increased in synthesis, however, it is balanced with increased clearance by the enzyme vasopressinase. There is a normal AVP response to dehydration and water loading despite a reduced set point in pregnancy. Oxytocin levels, on the other hand, they rise progressively with increasing estradiol and progesterone concentrations. The levels of oxytocin peak during labor with cervical dilatation. Oxytocin helps in aiding uterine contractions and fetal expulsion. Oxytocin receptors in the uterus, they increase 100-fold by term, enhancing oxytocin binding. So that was all about the hormonal changes during pregnancy. Now we'll discuss the endocrine glands in pregnancy. So what happens to various endocrine glands during pregnancy? The most important gland is the thyroid gland in pregnancy. The thyroid gland in pregnancy undergoes enlargement. This is because of increased follicle size and the colloid content. There is also increased blood flow of the thyroid gland during pregnancy. Possible reasons may be because of increasing HCG level, which has got intrinsic thyrotropic activity, and there is also increased thyroglobulin levels during pregnancy. The thyroid binding globulin doubles during pregnancy, leading to increased total T4 and T3 levels. However, the free T3 and free T4 usually remain normal. So T4 and total T3 levels, if we measure during pregnancy, they may be increased because of the increase in thyroid binding globulin, but the free hormones, that is free T3 and free T4, usually remain normal. There is no major change in the thyroxine binding prealbumin, but the albumin levels, on the other hand, decrease due to increased vascular volume. Hypothyroidism is relatively common in childbearing women, while hyperthyroidism is rare. The very important topic is hypothyroidism in pregnancy. It's altogether a very broad topic, but I'm just trying to cover a few parts of hypothyroidism in pregnancy. In pregnancy with hypothyroidism, basically the mother is responsible for providing T4 and T3 to the fetus, particularly in the first trimester, because the first trimester the fetal thyroid gland is not active, so the mother is the only source for providing T4 and T3 to the fetus. Thyroid hormone replacement needs to be increased as early as the fifth week of gestation. So remember that whenever you are encountering a woman with hypothyroidism in pregnancy, you have to increase the thyroid dose as early as fifth week of gestation. While these needs actually plateau in the second trimester, they may continue to rise into the third trimester for many patients. Uh, Increased dosage needs. There is around 50 to 85% of women with pre-existing hypothyroidism require increased thyroid hormone doses during pregnancy. The total dose may need to be increased by up to 50%. So there is a need for increased dosage of thyroid gland because of various reasons, and the dose needs to be increased by up to around 50 to 75%. Now, the initial assessment is that you have to check thyroid function at the first prenatal visit to determine if the dose adjustments are necessary. There is an alternative approach that you can increase the dose empirically upon pregnancy confirmation before the lab tests are even available. How will you monitor a pregnant patient with hypothyroidism? You perform thyroid function tests every 4 to 8 weeks throughout the pregnancy. And the important thing is that you have to ensure that the thyroid hormone replacement remains adequate as the pregnancy progresses. Now, there is some controversy regarding routine screening. There are certain schools which say that routine screening is not required, and there are certain other schools which advocate for routine screening. So, the current stance of routine screening is that routine screening is important to diagnose cases of undiagnosed hypothyroidism. Um, but it is not endorsed by major organizations. The American Thyroid Association, the American College of Obs and Gynaes, and the Endocrine Society do not recommend universal screening of thyroid levels in pregnancy. On the other hand, there is a targeted screening approach for TSH monitoring in for TSH screening in pregnant women. So this school of thought actually recommends screening for TSH in those women who have a family or personal history of thyroid disease, previous head or neck radiation, pregnant women who are morbidly obese, and age over 30 years. The rationale behind this targeted screening is that focus screening actually helps in identifying the risk factors, which eventually identify at risk individuals more effectively. So, this school of thought actually recommends focus screening or targeted screening approach for diagnosing hypothyroidism in pregnancy. Okay, that was about the thyroid gland. Now, what happens to the parathyroid glands and calcium metabolism in pregnancy? There is approximately a transfer of 30 gram of calcium from the maternal to the fetal compartment. Most of the transfer occurs during the last trimester of pregnancy. The maternal total serum calcium levels drop during pregnancy. This drop, the nadir, occurs between 28 to 32 weeks due to reduced albumin levels and increased vascular volume. So, you understand that there is a drop in the serum calcium levels during pregnancy, and the maximum drop occurs between 28 to 32 weeks because of reduced albumin level and increased vascular volume. The albumin adjusted total calcium, on the other hand, is slightly elevated compared to the non pregnant state. And the ionized calcium is also slightly higher in comparison to the pre pregnancy level. The parathyroid hormone, some studies suggest that there is an increase in PTH levels during pregnancy. Intake PTH levels, which is measured by a two-site immunometric assays, it usually remains within the normal non-pregnant range throughout the pregnancy. And what happens to the PTH related protein, that is PTHRP? Circulating concentrations of PTHRP, they increase throughout the pregnancy. So they are increased throughout the pregnancy, and they are likely involved in the calcium transport in the placenta and the mammary glands. Now, what happens to the 25 hydroxy vitamin D and calcitriol levels in pregnancy? The 25 hydroxy vitamin D levels usually remain unchanged during pregnancy, and the maternal serum concentrations of calcitriol or 125 dihydroxyvitamin D, they are increased. They're almost double due to estrogen-induced rise in vitamin D binding globulin. So, because of an increase in the vitamin in the protein, that is vitamin D binding globulin, and this increase occurs because of increasing estrogen concentrations, the overall concentration of calcitriol is increased. And there is also an increased biologically active free fraction of vitamin D in pregnancy. The free fraction is increased because there is an increased free fraction of calcitriol, and the contributors can be enhanced maternal renal 1 alpha hydroxylase activity, and there is also increased synthesis and secretion by the placenta. These increased calcitriol levels during pregnancy may contribute to enhanced intestinal calcium absorption during pregnancy. Now, have you encountered conditions of hyperparathyroidism and hypoparathyroidism in pregnancy? I have encountered many such cases, and however, both the conditions are uncommon during pregnancy, but they can lead to serious issues if present. Now, pregnancy and hyperparathyroidism. Pregnancy is actually a protective for management of hyperparathyroidism. The mechanisms are that fetal calcium uptake lowers the maternal serum calcium levels, potentially alleviating some symptoms. So, this is important. Actually, pregnancy is a protective factor against hyperparathyroidism because the fetus is taking up calcium, so it can actually lower the maternal serum calcium levels and potentially alleviating some of the symptoms of hyperparathyroidism. Common symptoms of hyperpara in pregnancy: in mild to moderate symptoms like nausea, vomiting, pain, renal colic can occur. Serious complications like kidney stones, pancreatitis, hypertension, bone disease, or hypercalcemic crisis. There are certain management challenges because of limitations on treatment options. Certain agents like bisphosphonates and plicamycin, they are typically avoided due to potential risks to the fetus. Calcitonin use in pregnancy, it can be used as it does not cross the placenta. However, the safety and efficacy of calcitonin during pregnancy are again not well established. Now, what about hypoparathyroidism in pregnancy? Hypoparathyroidism generally poses fewer risks. However, severe cases can lead to maternal and fetal fractures. Sufficient oral calcium and active vitamin D supplementation can prevent these complications of hypopara in pregnancy. So, what are the calcium and the calcitriol requirement in hypopara in pregnancy? There is an increased maternal calcium demand because there a lot of calcium is used up by the fetus. So, significant maternal calcium is consumed by the fetus during gestation, and this actually requires increased intake of calcium and vitamin D. The dosage is about 1.0 to 1.5 gram of elemental calcium per day, and the calcitriol, which is the active vitamin D, it is around zero point 0.5 to 1.0 microgram per day to maintain the serum calcium homeostasis. Now, coming to what happens to the endocrine pancreas in pregnancy. The pancreas, as we know, is responsible for secreting various hormones like insulin and glucagon. There is an enhanced glucose transport across the placenta via facilitated diffusion, and this in turn may lead to a fasting hypoglycemia in the mother. The insulin levels, the basal levels in the mother are usually normal, and after meals, there may be a hypersecretion of insulin following the meals because of insulin hyperresponsiveness. The insulin dynamics, the half life of insulin is usually unchanged during pregnancy. Uh, there may be an overall increase in insulin levels because of higher synthesis and secretion of insulin. Now, what are the overall metabolic effects? There is enhanced glycogen storage in the liver and muscles. There is also there is hepatic glucose production. On the other hand, there is a decreased production of glucose by the liver. Insulin resistance in pregnancy is quite common, and nowadays we are also seeing an increased prevalence of gestational diabetes. So, what are the factors which are responsible for causing insulin resistance in pregnancy? The most important hormones promoting insulin resistance is human placental lactogen, which acts as a counter-regulatory agent for insulin. The human placental lactogen it increases as the pregnancy progresses, and this is one primary hormone which is responsible for promoting insulin resistance in pregnancy. The glucocorticoids, which are again counter-regulatory hormones for insulin, they also rise during late pregnancy, and both of these hormones are responsible for causing insulin resistance in the later half of the pregnancy. Now, what happens to the glucose and insulin response during pregnancy? The glucose ingestion results in there is a higher level of increase in sustained glucose levels. There is also a greater insulin response after glucose ingestion, and there is a more pronounced suppression of glucagon compared to the non-pregnant state. So glucose ingestion results in increase in sustained glucose levels in the blood. There is a greater insulin response, and there is a more pronounced suppression of glucagon compared to the non-pregnant state. Now, lastly, coming to the adrenal glands in pregnancy. What happens to the cortisol dynamics in pregnancy? The cortisol binding globulin, there is an increased hepatic production due to elevated estrogen levels. The levels double during pregnancy. The total plasma cortisol triples by week 26, reaching a plateau until the labor onset. The cortisol production and clearance, the metabolic clearance is decreased due to higher cortisol binding globulin. The cortisol production rate also increases, and the free cortisol plasma concentrations also rise accordingly. So, overall, there is an increase in the cortisol binding globulin, there is an increase in the total plasma cortisol, there is a decrease in metabolic clearance of cortisol, there is an increase in the free cortisol level as well. The free cortisol levels are high in pregnancy. However, there is no typical symptoms of glucocorticoid excess or Cushingoid features during pregnancy. Now, why is it so? Despite having high cortisol levels, there is no appearance of Cushingoid features during pregnancy. This may be because of the anti-glucocorticoid effects of elevated progesterone. So, progesterone, which is increased in pregnancy, it acts as an anti-glucocorticoid hormone, and because of this, the effects of elevated cortisol levels are nullified. Now, what happens to the adrenal androgens? The androstenedione and testosterone levels also rise during pregnancy. And this is because of the increase in the synthesis of sex hormone binding globulin. And the sex hormone binding globulin is increased because of the increase in the estrogen levels. The free androgens, on the other hand, remain normal or low despite the elevated total androgen levels. Now, what happens to the dehydroepiandrosterone and dehydroepiandrosterone sulfate in pregnancy? The adrenal production rates of DHEA and DHEAS are increased twofold. The serum concentrations of DHEAs, the maternal serum DHEAs actually decreased to one third to one half of the non pregnancy levels. The reasons are enhanced 16 hydroxylation or 16 increased placental utilization of 16 hydroxy epiandrosterone sulfate for estrogen formation. The adrenal medullary function status it remains normal throughout the pregnancy. The 24-hour urinary catecholamine levels and plasma epinephrine and norepinephrine concentrations are similar to the non-pregnant levels. Now, what about hypercortisolism in pregnancy? Hypercortisolism is very rare during pregnancy. However, it can lead to menstrual disturbances and infertility. Actually, Cushing's syndrome is a cause of subfertility or infertility. So, pregnancy with Cushing's syndrome is very, very rare. However, I have seen one or two cases with Cushing's syndrome who eventually conceived with a lot of difficulty. And in the what are the causes of pregnancy with Cushing syndrome? Outside pregnancy, it is again Cushing's disease is the most common cause, and during pregnancy, it is mostly an adrenal source. If the patient with Cushing syndrome is pregnant, then the most likely cause is a ACTH independent Cushing's disease, which is it may be either because of adrenal adenoma or primary adrenal hyperplasia. The Cushing syndrome overall prevalence is very rare. Yeah, this slide I've already discussed. With Cushing syndrome, there is a high risk of hypertension, diabetes, preeclampsia, and even maternal death. Cushing syndrome in pregnancy is associated with a 43% risk of preterm delivery and a 6% risk of stillbirth. Now, lastly, coming to the renin angiotensin system in pregnancy, the plasma renin substrate is increased due to estrogen's effect on the liver. The renin levels also rise during pregnancy. The angiotensin 2 is also elevated due to the elevated renin activity. The aldosterone production is increased eightfold to tenfold during pregnancy. The aldosterone levels peak in mid pregnancy and they are sustained until delivery. Now, what are the effects of elevated aldosterone? In serum sodium, potassium, or blood pressure, we do not see any significant changes despite the increase in the aldosterone levels or renin levels. What is the possible explanation? The possible explanation may be again because of high progesterone levels. These high progesterone levels actually displace aldosterone from its renal receptors, nullifying the effects of aldosterone. Another mineralocorticoid, that is 11-deoxycorticosterone, it also shows a six-fold to tenfold increase in concentration at term. And the prevalence of hypertension in women of childbearing age has steadily increased over the time and is now a common problem which is encountered by obstetricians. Angiotensin-renin blockers, particularly the common drugs such as telmisartan or candesartan, valsartan, etc., they are very effective as an antihypertensive agents. However, they are absolutely contraindicated in pregnancy. Patients, if they are taking this medication, should be immediately switched to alternative agents prior to or even the first trimester of pregnancy. The antihypertensive of choice in pregnancy is methyl dopa, and it is safe for use at any point in gestation. Beta blockers are also often used, but again, beta blockers have also been found to be associated with an increased risk of fetal growth restriction. So one has to be careful while using beta blockers, and it's better if beta blockers are not used during pregnancy. So thank you. This was about the endocrine changes in pregnancy part one. I will soon come with another video covering the later part of this chapter, where we'll be discussing various other hormonal changes during pregnancy. So thank you and all the best for your preparation.